All right, I got the cue to go ahead and get started. Hi, everyone. Welcome to today's session on healthcare in rural communities. We're really excited. We have a couple presentations for you to start. And I wasn't originally supposed to be your moderator, Terry Lee's in the room here, but she kindly asked if I'd be interested in moderating. So my name is Sydney Senekis, and I work with the Rural Development Network. If you attended the rural and remote session yesterday morning, you probably saw my colleague and I, Emma, presenting. So yeah, really excited to be here today and excited to learn from you all. And first off, I just wanted to take a moment to acknowledge that this year's conference is being held on the traditional and unceded territory of the Anishinaabe Algonquin peoples. And the peoples of the Anishinaabe Algonquin Nation have lived on this territory since time immemorial, and their culture and presence have nurtured and continue to nurture this land. And we acknowledge and celebrate the many First Nations, Métis, and Inuit peoples from coast to coast to coast who participate in the conference and lead the work to end homelessness across Turtle Island. So we are going to be saving questions to the end. So we're gonna start with the first presentation and then we'll go to the next. I will introduce first, we have, and I do apologize, just give me a second here. So the first presentation is going to be on innovative collaboration practices in rural areas. And we are joined by, and my apologies for the pronunciation, but Christine Francoeur? Not bad, no, that's okay. And Antoine St-Germain? No, it's okay, no, yeah. And they're going to both introduce themselves because one of the bios is French online, and I do not speak French. And they're gonna both introduce themselves. So yeah, take it away.
Good morning, everyone. So I'm Christine Francoeur. I'm a social worker, actually, a graduate from University of Ottawa, and I'm now in Val d'Or, which is about a 5-hour drive up north from here. And I'm a senior homelessness advisor for the Integrated Health and Social Services Center of Abitibi-Témiscamingue.
My name is Antoine St-Germain. I am a regional clinical specialist of homelessness. So I give support to the frontline worker that work with homelessness to make an action plan about complex cases. So as you may hear, I'm from Quebec, and I will use some basic word in English.
So today we want to talk to you about innovative collaboration practices in rural areas, more specifically in Val d'Or, Quebec, where we are both from. What to expect today from our presentation. So we will give you a little bit of an overview of the situation, the reality that we work on. The Homelessness Clinical Committee, it's what we're going to be focused on, as well as its beneficial impacts and some partner-led projects.
What we want to pay attention is really the philosophy behind the project, because it's really with this multidisciplinary philosophy that you can bring back in your hometown, maybe adjust or create a new project, but it's with this philosophy that are with us in all the projects that we will speak about.
Before we start, we want to take a moment to acknowledge that our region, Abitibi-Témiscamingue, is located on the traditional, unceded, and unsurrendered territory of the Anishinaabe Algonquin people. We also want to take this time to express our gratitude and respect to them and to the land for all that it has provided us and continues to provide us. So some numbers. In Val d'Or, we actually have one emergency shelter service, and in 2021, we actually opened a second site to answer to the needs of the homelessness. So during COVID, rise of the homelessness situation. As you can see, over the years, the numbers have gone up. For the last year, we talk about 579 different users that use emergency shelter services only in Val d'Or. It can be people who use it for one night, or we have chronic users that sleep there almost every night. Of those users, 73 are women, 416 are men, and 61% are Indigenous. On average, we have about 30 users per night that use the emergency shelter services.
For homelessness, we have a lot of committee, but the best one is the Homelessness Clinical Committee that I'm part of, and Christine need to be on the 4 others.
So I'm the lucky one administrator that's part of all the committees. The homelessness clinical committees, it's first-line workers that are part of it for Val d'Or, so we meet once a week to talk about complex cases. The one just above it is a local committee in Val d'Or as well, which is the Strategic Committee on Homelessness, and it's to facilitate partnerships and work on specific issues. For the past 3 summers, we actually had a summer strategy that involves different partners with goals that we all take part in. We also have a governance committee in Val d'Or. It's for local deciders. So any issues regarding services or any needs that might show up or any collaboration issue will be addressed at that committee. And for our region, we have a governance committee. So it's all the deciders from internal and external regional partners, including community services and public sector. So let's say when we receive financing in homelessness, it's with that committee that we're going to present our action plan for the financing and how we're going to spend it, and we need to get their approval. And also, if there would be any bigger issue for the region, we can address it at that committee.
So about the Homelessness Clinical Committee is a group of frontline workers of different organizations that gather once a week to make action plan about complex cases. So it's really with the no wrong door approach. So every member of the committee know exactly what is the job of the other member of the committee. So for example, if some people came to me to make a ID in the identification and it's not my job, I will do it, or I will call back my partner to summon him for the make the job easier for the person.
So we started the clinical committee in 2015, and what we noticed is that we have maybe 1 or 2 first-line workers that worked in homelessness at that time, but we weren't getting any clinical support or any space to discuss cases. So the clinical committee also allows that support and clinical support and training as well for its members.
And it's really with the multidisciplinary approach that we take the needs of the person to take it in the center of the discussion, because we speak a name, we speak facts. It's with this information that we can make a little extra for having a whole puzzle, because each person on the committee have a little piece of the puzzle for the person. So when we take it together, it's easier for us to make a little extra. Because with complex cases, drug addiction, mental health issues, physical problem, people don't fit anywhere. So the anywhere is the clinical committee. So if everybody make a little bit extra, but the person at the center receive the right services.
So the users are known by most of the members, but some of the first-line workers might not have to work with the user specifically, but it's someone that we pretty much all know.
So the member of the committee, we have a police officer, we have me, Christine, we have frontline worker, we have a member of Friendship Center, a nurse from public health. So we gather once a week, 2 hours, the committee. And if other members want to join us, it's possible to be part of the committee just for the little bit of discussion that the person want to do. For example, the probation person can speak about 1 or 2 person that they want to see, and we will speak about it to make some action plan for the needs of the person, for the homeless person.
So we have 9 permanent members, and what I want to give a precision is that we have 2 police stations in Val d'Or. So we have the main police station that offers first-line emergency services, but since 2015, we actually have a community First Nations police station that was put in place at the same time pretty much as the clinical committee. So the police officer that's with us is part of the community police station where Antoine also works. And as I was saying, like a probation officer, she'll come to our committees about every 8 weeks. And it's specifically for users that she has a hard time reaching out to and that don't necessarily respect their appointments or go see her in her office. So it allows to have a better support system around the users.
So every member of the committee is a frontline worker, so it's really important that if you are on the committee, you can make intervention. So if we make an action plan, it's you and it's my partner that will be on the field to do the intervention. So it's not the boss taking decision for the frontline workers, really the frontline worker that make decision with the people, for the people.
I'm the only non-first line worker that's present. It's to give clinical support, and if there's any issues with collaboration or with a partner, I'm going to be the one that's going to take that information and do that little extra on the side. It's not going to be the clinical committee members. And we have 5 clinical committees in Abitibi-Témiscamingue, the 5 major cities, and I'm on all of them. So it allows me to have a general vision too, and users like to move around a little bit. So with that knowledge, it can allow to make different interventions too and give different support to the first line workers.
If you want to try to implant it in your own city, you will have the same issue that we all have, is how we get possible about the exchange of information. Community service, nurse, friendship center, normally they don't speak up together about facts and names, so we have a little bit.
We actually have a frame of reference that was put in place, and everyone's responsibilities and limits are part of that frame of reference. As I said before, we have 5 clinical committees on the territory, and it's not all the same actors, and it's not all the same frame of reference. So it's really important that it gives a picture of what you lived on ground with the users for it to answer the needs of those users. We actually have a disclosure form too between the partners. So let's say that our public health nurse brings us a situation about a user in a crack house and she gives an address. Well, the police officer is not going to take note of that crack house address to do a drug bust later in the day. If a user has some justice issues and that's mentioned by the police officer, well, we're not going to take that information and use it in our intervention, and we also filter what we say. The nurse might tell us, oh, I need to see this user because I need to talk to them to do a follow-up, and he's actually hepatitis C positive. If we don't need that information for our intervention plan, that information won't be disclosed to the whole committee, so we filter what we say as well. We also always get consent. I say always, but 98% of the case that we discuss, we get consent from the user. Usually it's going to be a verbal consent because we don't all walk around with consent forms in our pockets that the user can sign. And we make sure that that consent is still valid in time because the situation of the user might change. And if we need to have a case discussion because we're worried about someone, we will do so without any specific information about that user as well, to make sure to prevent the confidentiality of that person.
And for the verbal consent, each member of the committee do the same thing. If a person came to me and asked something, I will say I will discuss with my team. I will discuss in the clinical committee, and everybody know what is the clinical committee. So we get the verbal consent like this. And sometimes a person or two, these organizations are not mentally stable. So if we can't have the verbal consent, most of the time it's because we have danger. So when we have danger, we just speak about the danger fact to make a security plan for him or for the other.
We also all have the same message. So when we have an intervention that's put in place, we will all say the same thing to the user. So that prevents shopping around in services, something which some of them like to do. And our goal is really to answer the user's needs. So we always take it back to that one common goal. And also by working together, we're 9 different partners, so we know each other's services, but we also have to do that little extra because sometimes it just doesn't fit in anyone's services, so we can go that extra mile to make sure that the needs of the persons are met.
We really need to think outside of the box for marginalized people, so...
Big word.
Yeah, big word, big word. So in team, it's easier for the brainstorm and to do, okay, yeah, me, I will do that. Okay, if you do that, me, I will do that. So it's easier like this.
And by talking with each other, sometimes we notice like someone that's been extremely solicited by that person, let's say the emergency room, well, we have the nurse that's like, me too, like it's been quite something with that person in the last week. So by putting that information together, we can react more efficiently and more rapidly too for the users. Every year, we do a little annual report for the committee. So the last year, we named them positive shots for the clinical committee. So the members were able to get funding, for example, to organize activities for the members. We also were able to do a partnership with a local doctor, and we actually have an acupuncturist that offers her free time to treat some addiction and mental health issues for our users.
And it's important to us to, when we make activities, that the person see us together, working together, even with the police, even with the nurse for Friendship Center. So when we organize activities, cinemas or popcorn, hot dog dinner, we are all together to participate in a positive way.
We also do activities for Christmas and other holidays where most of the users would generally be alone, and all the members are usually present too. We also have positive shots for the user. It's not what we see as a positive shot as clinical committee members, but it's what the users see as positive little success stories. So we were lucky enough to have our emergency shelter open a 40 housing unit for the users of the services. So we got some integration over the last year, safe pregnancies too for some women users that we have, and also tapage, which is a work program that pays the users per day. And we have a partnership with the city for that program as well.
And sometimes it's just to stay out of the justice problem. Sometimes it's just to go to an appointment. So it's not a big success. Sometimes it's a little success, but big for the person.
On average, during the committee, there's about 20 case discussion, and we also have from our users 27 patients that are followed by Dr. Gendron via the community psychiatric clinic, which we will talk to you about soon.
Yeah, and the case discussion is not always a 15-minute case discussion. Sometimes it's just a follow-up for the discussion that we had last week or last month, just for make sure that the frontline worker do the follow-up. And when it's when the person is at everybody, sometimes nobody do the right thing. But with the committee, it's the person take care of everybody. But we need to make sure that everybody
does their little bit.
Yeah.
So we have some examples for you guys. So we invite you to pick one of our cute or not so cute image.
So we need to pick. You need to pick one. Just say it out loud, and we will tell the story behind it.
Superman.
Great one.
So it's a user that used to have multiple 911 calls for mental health issues, some drug addiction issues as well. And what we noticed is when we sat down and put all of our information together is that we were able to put do a guardianship request to assure the security of the user. After that, we were able to put the guardianship in place. We actually scheduled visit to his apartment. So instead of being Antoine that goes every day to see him, it's different partners from the clinical committee that would go see him and try to keep that bond alive. There was also a good bond with our nurse. And instead of getting him to go to the hospital to get his antipsychotic injection, it's the nurse that would go give him directly to his apartment with his consent. And also when he would be hospitalized in a psychiatric unit, we would keep going to visit him to make sure that we're still there for him, if there was anything he needed, and to talk about once he would get out of the hospital, what the plan was and if he needed anything. And also with Antoine, you did a bit of justice
follow-up. So
with him?
With the committee, the clinical committee, at the beginning, it was the Friendship Center that had the link. They made the guardianship request. And after that, the Friendship Center was more like a backup. So I take the leads for the justice problem, and the nurse take back after. So what is beautiful with the clinical committee is we can share about the tasks that we need to do, because I don't have the time to visit the Superman guy 3 times a week. but all together we can do once a week, and it's really important to him to have this kind of support.
And we named him Superman because I think one of the last 911 calls that we got for him is after taking some speed, he actually flew out the window of a second floor apartment building. So.
And he loves superhero.
Oh, really?
Yeah.
Oh, I didn't know that. Well, we've talked about some of them, but the beneficial impacts, like just before we started, our text messages were going crazy because there's a clinical committee going on right now. And one of our users actually is supposed to be in court for, I think, 10 o'clock, and we couldn't find him. So with that communication, what we realized this morning, that he's actually at the emergency room because he got into a fight last night. So by texting each other and sharing that information, we can get really up to date quickly. Also, what we've noticed is that all important information like medical appointments, because most of our users don't have a cell phone, well, if the nurse is the person that receives this information and gives the information to the clinical committee with via text message, well, the first one to see that person during the day can tell him about the appointment and even offer a ride or transportation via taxi. There's also less shopping around for services or special permission because we all are up to date on their information and we all are part of the intervention plan. Less division in our services too because we comprehend each other's services that are in place. We all work together towards a common goal, and we actually have a really good recognition from our partners, more precisely the city. We have some encampment situation on our territory, but we're pretty lucky because our resources are able to have enough room for everyone, but some users prefer being in an encampment situation. But with the city of Val-d'Or, they will actually get in touch with us when there's an encampment, and we're not talking about hundreds of them, so that's why we can do it this way. And once we're aware of the situation, we can go towards that person and try to forge a bond, see if they need anything to ensure the security, and maybe eventually if they want to bring them to the homelessness shelter. We've noticed fewer emergency room consultation, fewer missed medical appointments as well. We have a good partnership with community pharmacies because if we have an individual in front of us that wants his medication right here, right now, they're usually really good at preparing that for us to make sure we can bring it to them.
And we have a small window of opportunity when a person want to do something. I want to do some treatment to drug addiction. I want to take my medication for my mental health, for example. If we wait 1 week, 2 weeks, 3 weeks, the needs will disappear and the window will be closed for maybe a month, 2 months, maybe a year. So it's for that we are that we gather once a week to really have a quick response for the needs. And sometimes the person say, yeah, I want to start my medication. The nurse will go to the pharmacy and bring back to the frontline worker. The frontline worker will find him. The nurse will give the medication, and within an hour we will start a medical treatment, for example.
We've also had to turn to the justice system for some of our users that needed a legal measure put in place. We have a good partnership with the lawyer from the Centre de Santé, and we've actually, like I said before, the clinical committee over the years we actually put in place in all 5 major cities in Abitibi, Témiscamingue.
So the clinical psychiatric clinic is the psychiatrists that come downtown to give psychiatric meeting with the person experience homelessness. So it's the same team that are in the clinical committee are into the community psychiatric clinic. So it's with the same philosophy that before the meeting we will share the important information for the psychiatrist to know, and he can make a nice meeting with it, and after that he will make a debriefing to the follow-up during the month. So the doctor don't have the clinical file with him, but have the observation of the frontline worker that often are better than the file, the classic file.
So it was put in place in April 2019. On average, Dr. Gendron, we see 8 to 12 patients per clinic, and it's actually him that came towards the clinical committee to say, I see a lot of your patients at the emergency room. I refer them to third line psychiatric services. They don't show up. We can't reach them. They don't have a valid phone number. The next week, the next month, they consult again. So we said, can we try something, see if it works? And it works really well. And he will meet the users where they're at. So it might be at the police station if that's where the user feels most safe, his apartment, the emergency shelter, on the street. So he goes towards them.
And the major point is to forge bond. It's not to introduce medication, it's just to forge bond, because without it, we can do anything. So sometimes it take 8 meetings, sometimes 1 year, 2 years, 3 years. And when is the time when the person raise their hand, we will be there for him.
And he's also available in between clinics. Let's say we introduce a medication for a user and there's side effects, we can text him, we can call him, there will be an adjustment. And as well, he offers us clinical support as well. We might think that we're where we need to see a psychiatrist, but he will tell us, well, try this and this, give us homework for the month, we try it, and then we discuss it again with him the next time he comes and see us. And we actually received in 2022 a Prix Hippocrate Jean-Paul Marsan for that multidisciplinary work we do with Dr. Gendron, as well as the different trajectory that we offer users for psychiatric services.
So another one project, we will start the video because it's a beautiful video. It's in French, but we have a subtitle in English.
PETAPAN, c'est un projet de sécurisation culturelle qui est mis en place par le Comité stratégique en itinérance de Val-d'Or. En fait, c'est tout simple comme projet. C'est d'offrir des services aux usagers dans le milieu où ils se trouvent, donc aller vers eux. Puis on le fait via le biais d'un motorisé de 32 pieds. C'est vraiment de remettre l'usager au centre de nos interventions, au centre des services, et de décloisonner nos diverses offres de services, autant dans le communautaire que dans le réseau de santé.
C'est grand, c'est voyant, donc c'est vraiment une belle image. Quand les gens nous voient dans la rue, ils arrêtent parce que c'est vraiment une belle métaphore là, du travail d'équipe et de collaboration. Donc là, on retrouve tous les services à l'intérieur d'un même motorisé qui va vers les gens. Donc c'est l'idéal dans les meilleures pratiques là, pour ce qui a trait aux personnes en situation difficile.
Notre première mission, je pense que dans mon travail, c'est de créer des liens avec ces gens-là. Puis après, la suite se fait plus facilement. Ils reviennent vers nous autres quand ils ont faim, quand ils ont froid, quand ils ont besoin de quelque chose. Des fois, c'est minime, ça n'a rien à voir avec les soins infirmiers, mais on les aide. Puis par la banque, je vais réussir à récupérer ces gens-là pour leur offrir des meilleurs soins, une meilleure qualité de vie. Puis des fois, on ne fait pas grand-chose, mais on accepte ça.
On parle de problématiques de consommation, on parle de problématiques santé mentale, de déficience intellectuelle, on peut parler de problématiques de violence conjugale, donc de prostitution, vraiment au niveau de la vulnérabilité, de la rupture sociale ou à risque de
Ça nous permet aussi de faire des activités de prévention, d'avoir plus de matériel aussi dans le motorisé, fait qu'on peut parler de bouteilles d'eau, de popsicles dans les temps de grande chaleur, de matériel de consommation stérile également. Donc, c'est comme un entrepôt roulant avec des intervenants à l'intérieur qui peuvent faire l'intervention dans le ici et maintenant selon les besoins des usagers.
Ça prend beaucoup de compréhension d'où ils viennent. On est là pour eux autres au moment où ils en ont besoin, pas quand moi je veux, mais quand eux en ont besoin.
So it's actually during a strategic committee that the idea of buying a motor vehicle was brought to the committee, which they all said, okay, let's go, let's do it. So PETAPAN has been in place for 3 summers now. It's actually part of a cultural safety initiative, so it's really aimed at changing our practices within a shared governance. So the vehicle is owned by the Centre de Santé, but it's a bunch of different partners that have a schedule and that give their time to do some PETAPAN. So let's say the probation officer might come do a 3-hour block during the week to go towards its users and get in touch with them. And it's health and social services, and it can be a different community organization as well. We are based on the no wrong door approach, just like the clinical committee. So we want to take the services out of the box and we want to go meet the users. And last summer, so summer 2024, we actually organized 34 different activities. We reached over 900 people, and it's 30 different partners that are involved. And we also work on improving cohabitation in Val d'Or, so we have different prevention activities as well in downtown Val d'Or.
And everybody on those projects have the full-time job, but we take time to do the psychiatric, the PETAPAN, and the clinical committee because we save so much time at the end. But it's hard to take the time right now, but it's really make way more sense for the people.
And I love how this picture was taken just 2 weeks ago, but we all look so cold. Also with the strategic committee, last year we noticed a gap in services. So in the morning between 8 till 11, 7 days a week, we didn't have any services offered to our users. So let's say that the police would actually be called because we had a bunch of users near an ATM that needed to get out because clients weren't going in, or the emergency room would let someone go after they had a consultation while they were on the streets. It can get pretty cold in Val d'Or, about minus 40s on a good winter day. So with all the partners, we actually put some pressure on the government, and they gave some funding to La Piole de Val d'Or, which is our emergency shelter, and they accepted to open a drop-in center, open every day from 8 till 11. So there's always one first-line worker from La Piole that is present, and there's always a second first-line worker that's present as well. So it can be Antoine from the Centre de Santé, it can be or mental health drop-in center that's present as well. So in the past year, we actually had 12 different partners involved. On average, there's about 22 users, but in the last week, we've seen that number go up as high as 40 different users that were present in that morning time.
So that's it, right on time.
That's it. Yeah.
All right. Thank you so much, Christine and Antoine. I think that was a fabulous presentation and an amazing collaborative model. I think that a lot of us could learn from. So I know I have some questions, and I'm sure others will. But we'll maybe move forward to the next presentation. And we have three lovely presenters. I'm going to read out a couple of their bios, but they're going to be talking about housing and health, what happens when we work together in community. Now we have Caitlin Currie with Grey County Housing. Caitlin is a queer Irish settler who worked in anti-racism and gender justice community organizing before finding a home in homelessness services. Caitlin is employed at the homelessness response the homelessness response supervisor at Grey County Housing. Caitlin holds a Master of Arts in Gender and Women's Studies from the University of Toronto and has previously worked in transitional housing, emergency shelter services for youth and families, and as a mental health and addiction supportive housing case manager. Perhaps the most valuable experience Caitlin brings with her, though, is her lived experience as a survivor who has navigated systems from her personal and family use. Joining her, we also have Teresa Thibault presenting today, and she is a paramedic with Grey County Paramedics. She is a primary care paramedics on the SOS team. She started her work in healthcare as a registered practical nurse in LTC. She returned to school for paramedic training and has been working with Grey County Paramedics ever since. She has settled into the SOS role and enjoys working with a team of like-minded individuals. She is passionate about breaking the stigma around mental health and addictions and helping our clients access the care that they deserve. And then we're going to have Teresa and Caitlin introduce Heather Prescott, who's a nurse practitioner with Bright Shores Health System, since we didn't have a bio for her. So pass things over.
So we're going to say Heather didn't do a bio, but she did. So I'm Caitlin Currie, and I've been working with folks experiencing homelessness for the past 10 years or so. And I often found myself fighting with healthcare professionals. And I would say advocating, but actually it was fighting. It was fighting to get clients to be seen, to be heard, to be supported in their medical transition into housing. And until I met and worked with Heather Prescott, I had never worked with a healthcare professional who's such a badass, and for the people. And for the people, for sure. So Heather provides street medicine to the most marginalized people in Grey County. And as I said, she's just generally speaking a badass. She speaks truth to power every single day. She's a weirdo, and I admire that. And she also brings with her lived experience, and she's a fantastic single mother to 4 children as well. So it's an honor to introduce Heather. I am a weirdo.
All right, so I'm going to start us off this morning. A paramedic, a housing worker, and a nurse practitioner walk into encampment was the preliminary title for this presentation, and perhaps why we were selected this year. While it sounds like the beginning of a joke, it's something we do every single day. Communications instead decided it wasn't a good idea, and this is the title we've been left with. So just a quick agenda today. We'll go through some objectives. Of course, we're very happy to be here this year. This is not our first attempt at speaking to you. We're really happy to be here. We've learned so much already, and we really hope to expand on that together today. Objectives today, we do aim to demonstrate the critical value of building relationships and collaborating in care. Specifically around individuals accessing emergency motel services, which is really all we have in our county, those sleeping rough, and especially those in the highest acuity of need. That's when Caitlin calls us. Also, we wish to share some best practices from our rural frontlines. Very frequently we hear what the cities are doing to help in those innovations, and I really think there's lots to be learned from your rural partners and how we've had to be pretty gritty about how we get stuff done. We feel we've transformed traditional healthcare barriers into bridges of support. We meet individuals where they're at, both physically and figuratively, and we've been successful in reducing that cycle of homelessness in our community, and hope that you can take from that to yours.
So my one joke I have in here is about to come up, so be prepared to laugh. For those of you from outside of Ontario or from Toronto, this is where Grey County is. We're about 2.5 hours north of Toronto. So we're not a remote community, but we are a rural community. And then this is the more focused in map. So that's our geographic area, and I'll mention it as well, but we also work very closely with our neighboring county, which is Bruce County, and I'll speak a bit about that. But you often hear, if you're from Ontario, you probably heard Grey Bruce. Tobermory, that's Bruce County right beside us. That's normally how I try to describe it, is if you've heard of Tobermory, just we're a little south of there. So I'm going to provide just a brief background on homelessness in Grey County. So Grey County is 4,500 square kilometers. And as I mentioned, we can't talk about homelessness in Grey County without also talking and acknowledging Bruce County. And we partner with Bruce County for our coordinated access system and by name lists. And with Bruce County, the geographical area is about 8,500 square kilometers. And I've only found out recently that about half of or over half our population lives in a rural area, with only 47% living in small population centers. And what I mean by small population center, Owen Sound's the largest town in our area, and it's just under 20,000 people. And then all the small towns around there are like, I live in a town with a stop sign, and that's about it. And we say there's 20 people there. I'm sure there's more, but so just to kind of paint a picture. So the 2 counties are composed of 17 lower tier municipalities and 2 First Nations communities. And I'll explain a bit about the 2-tier system, but I also wanted just to take an opportunity to acknowledge the territories that we work on. And I will say I actually grew up in Ottawa on Algonquin territory, and Ottawa was not always kind to me, but it is really beautiful to be back on these territories and create new memories here. In Grey Bruce, we're on Anishinaabe territory, and the 2 First Nations communities, which are really leaders around both healthcare mobilization and homelessness in our communities, and that's Saugeen First Nation as well as the Chippewas of Nawash Unceded First Nation. So for those that are unaware of, until I moved to the area, I wasn't familiar with two-tier municipalities, but basically we have a regional county municipality, which is Grey County or Bruce County, and then we have the lower tier municipalities, which are like Owen Sound, and they have their own council, and then they make up the greater county council as well. And it makes for fun times of who's responsible for what, and it gets very complicated and muddled sometimes. And the county is who receives the homelessness funding from the province, and we ultimately are the service manager. But they're, the municipalities or the lower tier municipalities, for example, have their bylaw services. So we're often dealing with a lot of different bylaws, not just one, to talk about in CAM and outreach, for example. So why do we partner with Bruce County for coordinated access? First and foremost, households experiencing homelessness often move between the county boundaries, and that could be for a variety of reasons. Some folks may travel between the counties because they have employment on one side of the counties. Other folks may find a couch surfing option with family or friends in the other county, yeah, so they often travel and accessing services in one part of the county or the other. Additionally, the services in Grey Bruce are offered across both counties, and I'll speak a bit to what's unique in Grey County, but we have, for example, Canadian Mental Health Association, and they are the one branch serves Grey and Bruce County, just as an example. And then finally, and as many of you who do live and work in rural spaces would know, it's just smart to pool resources. We're under-resourced in our communities, and so it made sense to pool our resources and work together on this. Services unique to Grey County. So Grey County Housing offers emergency shelter services, whereas in Bruce County it's offered through a nonprofit. The SOS team, which Heather and Teresa are from, is unique to Grey County. And then we also have a drop-in center in Owen Sound. And I don't just mention that because my wife's the executive director. I also bring it up because it means that a lot of people end up going to Owen Sound to access services, especially because they run in from the cold program in the winter months as well. So coordinated access in Grey Bruce. So this is actually a mistype, but we've had a by name list since 2018, I want to say. We have a common consent form and referral. Our form, we originally were using the SPDAT, and the Indigenous leaders at the table quite eloquently pointed out how problematic the SPDAT can be, in particular around recognizing demographic markers that lead to marginalization and barriers in terms of securing housing and folks' experience of homelessness. So we actually created a tool from within the counties to use as a referral form, and we're currently undergoing revisions to create an even better tool. We have a homelessness response steering committee, so that's made up of specific partners that are working within homelessness to kind of guide the system and the direction of the system. We also have a Frontline unhoused response committee, which is kind of like a case conferencing table, and I'll talk a little bit about that later. Really cool thing, and I'd love to talk more about it if people are trying to get your community to do this, but in both Grey and Bruce, 1 in 10 of each of the county's rent geared to income units go to the by name list. So we do have, the chronological wait list. We do have priorities around like the special priority populations, which is folks fleeing domestic violence and trafficking. But on top of that, the counties have committed 1 in 10 units to go to the by name list to someone experiencing homelessness. And I can't express how amazing that is, because I know folks I've worked with that fall off the chronicle wait list because they're experiencing homelessness, don't have a phone, hard to track down. And this is really an equitable way to recognize that their name would have already come up. And they actually probably already should have gotten housing a year ago. We also have 16 nonprofit housing units that are dedicated to the by name list, so they take tenant selection through the by name list. We reached quality by name list in 2023, and we're supported by a lovely advisor from Built for Zero that helps us shape our system as well. So this is just a little graph to show you where we've been since January in terms of number of folks experiencing homelessness on the by name list. And so this is just from January to September of this year, but you can see that we generally hover around the 200 mark. And as of September, we had 193 people actively homeless on the by name list. And just some data to kind of shape the narrative as well. So 78% of households actively experiencing homelessness on the by name list are experiencing chronic homelessness. I don't think this is unique to Grey Bruce. You probably all the communities you're working in are seeing really disproportionate rates of folks who are already chronically homeless. 28% of individuals on the by name list self-identify as Indigenous, and in doing a quick search on StatsCan, I was able to find out that between the two counties, Indigenous folks only make up 2 to 4% of the population, so hugely disproportionately represented within the homelessness community. 21% of households are families with children with them. And 88% of individuals on the by name list identify that they struggle with their physical health, mental health, or substance use concerns. And I always, when I do training within Grey and Bruce, I always share this stat because it really speaks to that homelessness is not simply a housing and income issue, that we all need to partner in order to support people in securing and sustaining their housing. And also that many folks need to have other things addressed alongside trying to find housing, because they're getting in the way of, if you don't know where you're going to eat at night, that's hard to have a conversation about where you're going to live next month. And about 25% of those experiencing homelessness in Grey Bruce are sleeping rough most frequently. So that's a quarter of our population experiencing homelessness often sleeps rough. And I will say that in moving to a rural area, I used to live and work in Peterborough, shout out to Peterborough, there's a significant number of people that sleep in unseasoned trailers and also abandoned buildings in the rural spaces. So a bit about Grey County Housing. So as I mentioned, we're the service manager. In 2019, we, along with our community partners, created the Grey Bruce by name list. In 2021, Grey County hired a position in-house to focus on strengthening coordinated access on the by name list. And then a huge shift for Grey County Housing was in 2022, we brought emergency shelter services in-house. And so what that looks like, we don't have a bricks and mortar congregate shelter setting, but what we use is motels. So previously we were using private market motels, and that proved to be very challenging for a number of reasons, including vacancy, including rules about pets in motels, needing ID, and banning people was the hugest thing. Like, we would have our own system in place for how long of a service restriction someone would get for X, Y, and Z, but then the motel would say, no, I'm never taking that person back. So how do we offer services when a business is denying the service? So in 2023, Grey County funded an overnight winter warming program for the first time at the Owen Sound Drop-In Center, and we'll continue to fund that this year as well. And we can't do the motel service without having the drop-in space because the motel doesn't work for everyone. And also some folks don't want to be in the motel or don't want to access a service that's offered by the municipality. So having that secondary option through a non-profit, and as much as I'd like to think that we're trying to run a really low barrier motel program, it is still operated through the municipality, and we serve a variety of different people. So sometimes there are barriers in place. And so the overnight winter warming program offers much lower barrier access programming for folks. So then in 2023, we also ramped up our in-house programming by having, the team of staff working at the motels. We were also able to include encampment outreach. So we do a lot of encampment outreach across Grey County. And then finally, the really exciting thing is in 2024, so in March of this year, we purchased a motel. And I have some pictures on the next slide, but we run a 22-bed motel in Owen Sound. It just made sense economically, the amount of money that we were spending on private motels and get the renovations happening in those motels after we dished out a lot of money. It just made way more sense to invest in our own property, and we were able to have the control over it. We were able to use our own practices around service restrictions. We're able to bring services to site in ways that we weren't able to in the private motels. And this photo is that one day, two of my staff told me they had never set up a tent. And I said to them, how do you possibly think you're going to do encampment outreach and try to support people sleeping rough if you don't even know how to put up a tent? So I made them put up a tent. This is our motel before the purchase of it. I don't have any photos of it currently, but it basically looks the same without it saying the diamond. We call it our short-term housing program. And happy to chat more about that because I know it's a pretty unique model as well. So I could talk about that for hours. So I will pass it off.
Excellent. Okay, it's probably what makes me a weirdo is my enjoyment of street medicine. So I haven't practiced in a traditional medical office pretty much ever. At least in the last 15 years, I've always been working with unrostered individuals that didn't have access to primary care, whether it was diabetes, mental health and addictions, and now in the street. Our teams are so fortunate that we have access to a really dedicated leadership that do empower us to make some pretty big decisions in how we meet the needs of individuals accessing our services and supports. So in the example in the picture here, local fire took us out on ATVs. We've done this more than once to most efficiently reach and provide basic necessities like primary care, harm reduction supplies into the deepest encampments in Grey County. We have a Bruce Trail runs right through us. It's a very popular place for individuals to really seek solitude. It's really hard to access and hard for them to get to us, often more than an hour outside of our closest clinic. And fire enjoys it, I think, too. It's good for everyone. So we take a lot of stuff with us when we do these kinds of encampment outreach. And then fire's there, too. There's been at times when offer fire blankets, been able to offer CO detectors. There's been opportunities for them to engage as well in a non-punitive, non-bylaw way. Everyone seems to get it, which is really, really great. So this street approach delivers care to individuals experiencing homelessness in their communities. It focuses on addressing the immediate need of populations while building trust and rapport. And I think that's been said again a few times today that, sometimes we have to give out a pair of socks every single day for them to come back, a week, a month later and ask for, the wound care that they need. And after the wound care, they might start speaking to us about harm reduction and gear. And then we might get to addictions medicine. We don't always get there, and that's absolutely okay. This is our model of care. It's colorful. It's a lot. I didn't make it. It's a few years old now. So our mobile model of care includes an NP, paramedic, 2 mental health counselors, and a social navigator. We feel it's revolutionized how we serve this marginalized, vulnerable population, often overlooked by the corporation that is the health system or the hospital. We have 1 major hospital in the region and 6 small sites. They often can't meet the need. So we've got relationships. You can see there's several on there, but we have up to 25 partners that we work with. Many are non-for-profits. Police are even in there. They give us a very wide breadth to do the work we do, so folks can access health services without fear of being arrested when they come to our drop-in clinics, for example. We work with our food recovery. We work with our food banks. We work with many, many not-for-profits. CMHA, our public health is incredibly supportive with our work. They partner with us and come to most of our drop-in clinics offering harm reduction and sexual health right there and then when we're present. Grey County, obviously, and Grey County paramedics have been wonderful. I work for the hospital corporation, but I never go in that building. So some of the services that we offer, it's shifted over time. I'll talk about it in a few minutes, but we're born of a COVID outbreak in a rooming house. So COVID response was a huge part of how we got buy-in with all of these agencies initially. So we still promise to be there. We continue to have outbreaks, influenza in our rooming houses, for example. So that's still part of what we do, but we certainly have shifted significantly into medical care, addictions medicine, primary care. Mental health wraparound supports. There's a bottleneck to mental health counseling, I think, everywhere, trauma-informed counseling. So our mental health workers do carry a caseload until they can get into more long-term supports. So our timeline, again, so SOS was formed after the observed impact of this multi-organizational approach when there was a COVID outbreak at a rooming house. This rooming house probably was supposed to shelter about 20 people. There was over 44 staying there at the time. Identified mental health addictions, people not connected to Ontario Works, without ID, domestic violence, sexual abuse. The works was happening there, but nobody knew about it or nobody wanted to know about it. So community partners from both health and social sectors came together to organize this rapid response. The focus was on individual needs, and that really hadn't been done before. So when individual needs were being met, like having to manage alcohol withdrawal, having to get clothing laundered for individuals who weren't allowed to leave. That was at the peak of COVID. Trust was built. And we recognized that once we had this trust, the safety of the persons that were living there, they didn't want us to go. So after the outbreak, about 4 weeks later, we were asked to continue to stay and in some capacity deliver the same sort of services, and that's how we came to be. So initially we showed up at a church every 2 weeks to deliver care, and that model has now, we do it everywhere in Grey County. Some places were available daily, some places were available monthly, depending on the need. So as the project evolved, there was an obvious identified need to be mobile and to be in more of the places. As Caitlin mentioned, we can't get to every stop sign community in our region, so being mobile really changed our ability. So in January, we were OH West funded, and our team is now secure, but we're only 4 days a week. And I think there's a lot of other communities talking about, well, we're only funded for 3 days a week. We know that that's not enough to meet the need. We leave still some really big gaps. Of note, that same rooming house that we used to serve burnt to the ground about 6 months later, a year later, and all those individuals were dispersed within our region. So where we had a spot we could go reliably to see folks, that disappeared. And finally, this graph is a lot, I get it, as well. Colorful gem, I like to call it. It really demonstrates our really robust evaluation thanks to Grey Bruce Public Health. That's not something I want to take on. Public Health does this for us. We measure all of our interventions. We measure a lot of demographic data, but without client information specifically on it. The kind of substances you're using, the kind of treatments they're accepting, whether we're providing counseling, primary care support, education, addictions medicine, how much basic needs, how much food we're giving out, it's all tracked in a pretty simple form. So you can see a huge blip there in the red. That's when the fire occurred. So all of those agencies came back together and for a period of time really intensified our involvement. And you can see that things have kind of leveled out a bit. There's, again, addiction is a chronic relapsing condition, and homelessness, of course, we serve a lot of folks who are chronically homeless. So we do see a lot of the same individuals again and again. Some do move on to more permanent, stable treatment options. Okay, and that's where I'll leave you.
So now we want to start talking about the specific partnership between SOS and housing. And so Grey County Housing only hired the first sort of homelessness specific staff in 2021 after SOS formed through the COVID outbreak at the rooming house. But soon after, I started attending the fixed sites that Heather mentioned and started developing relationships with the folks at SOS and the folks they're serving. And so it was an informal partnership in 2021. And often we would come together, often around this specific rooming house as well, to try to connect people to resources, to talk about some of the complexities specifically around housing, how they're trying to access emergency shelter, things like that. And then as the fire happened, Grey County was a huge player sort of in responding to the fire as well, and it just was sort of a catalyst for this relationship to be propelled even further ahead. And then as programming moved in-house with Grey County Housing, it again presented another opportunity to just strengthen and formalize that partnership. So that's sort of where it began. And so this is our by name list consent form, and this is actually sort of the crux of our relationship. This is how we share information with each other. So we use our coordinated access consent form, which has a lot of information on it that went through Grey County's legal department, and it is also for our HIFIS as well, although we'll talk a bit about that later, but we're not all using HIFIS at this point. But this is what enables us to actually work together and talk about the people. And as many of you are aware, it is often challenging sort of negotiating consent with health partners. And I think that the work we've been doing together really speaks to that it's the bureaucratic nature of the beast that's causing that problem, because clients want us to talk to each other and support them. We want to talk to each other and work together and collaborate. And then it's when it goes through a privacy officer that it's held up. And I'm not saying that to say that I don't care about consent and privacy. It's very important. But when it's not working for the people we're trying to serve, that's when it's a problem. And I do think that COVID offered an opportunity to put more weight in verbal consent. And we used a lot of verbal consent during COVID, or we do a lot of our services to get people into our motel over the phone initially. So verbal consent has also offered an opportunity to be able to work together in ways that were more challenging when we're trying to get everyone to sign this form and read the legal speech in it. We can explain it in our own terms and talk to service users about why we're sharing information. And with that too, like we often meet with people together. So there's conversations about, okay, like Heather and I are going to go back and try to work on this thing together. So those conversations about consent are they happen with that sharing of information all together in the same space. So I'm going to just briefly talk about frontline leadership, and part of my role is to implement coordinated access in Grey Bruce, and I have to say that my job would be impossible without the great leadership of folks on the front line. And SOS has really bought into coordinated access in ways that other housing providers haven't. And they have enabled the system to get more buy-in from other people who maybe aren't going to hear it from me because I'm the mouth of the county talking about something that the provincial government wants us to do. But when they hear Heather and Teresa talk about how there's this really great thing called the by name list, and this is what we're trying to do with it, it actually is a lot more, gives it more credit and vouches for the work that we're trying to do on this more coordinated level. So really the teams are leaders in coordinated access locally. We do a lot of case conferencing and we initiate a lot of case conferencing, and oftentimes when I'm at a case conference, it's very apparent that SOS or housing are taking the lead and are the ones who called it. And really, I think that's so important because we're mimicking how others can also take roles of leadership in our community as well. And when I call a couple case conferences, maybe the third one someone else is going to call it because they'll see that it really worked out in previous ones. We also have a Frontline Unhoused Response Committee, and this is a committee within our coordinated access system. It's not without its challenges, but its intention is to be a case conferencing group. It actually sounds very similar to the work that you guys are doing, and I'm hoping to learn and take back some of the ideas that you guys have for this committee. But again, like we often come together and talk about some of the really complex cases, get ideas from each other, share resources when possible, and it is often SOS and housing who are leading those conversations on that committee. And then I also just wanted to mention a new initiative that both SOS and housing has members on and are taking a strong leadership role in, which is a project around palliative care and improving equity to access for folks experiencing homelessness as well as Indigenous folks in our community. And so I could also go for hours about aging population of folks experiencing homelessness and how there's no dignity in death with the current system for folks experiencing homelessness. And there's some really cool stuff happening, conversations at the table around that, and SOS and housing are there often on a united front to try to ensure that the realities of the folks that we're trying to serve are not lost.
The team meets with housing at the motel once weekly, along with Muikwidong Indigenous Services, to discuss cases. We provide wraparound mental health, addictions, and low barrier primary care. And if we find that we're able to be involved with people while they're in the short-term shelter program, it gives us the opportunity to build trust and rapport so that can carry on when they're moving on to more stable housing. So an example of how this happens, the teams work together to provide wraparound supports to a pregnant client wary of the systems that have failed her in the past. The team was able to be present and available in a non-committal way so she could access supports when she was ready. Sharing information between the teams was important to provide a fulsome, holistic picture for case management. We also had a chronically homeless street-involved male in his 50s suddenly gain custody of his 4-year-old child. The team identified early intervention supports as fundamental to keeping this family together and supporting the dad. A case conference was planned with the family involved to bring together supports that our teams don't often work with. Rapid rehousing was facilitated to ensure the child was in a safe and comfortable environment, and the dad was supported for this life-changing event of having custody of his child. Housing and SRS are only a call away from each other. If SOS is at a location and finds someone that wants to discuss housing, we'll connect them with housing, and most often a worker can come the same day. Likewise, if housing has found someone in need of medical supports who can't wait until a scheduled visit or can't make it to one of our markets, they'll give our team a call and set up a visit. If someone wants to do testing of their drug before consuming it, they can access drug testing kits, the DIP kits at the motel. And if they're looking to have a more fulsome test, they can access SOS for our mobile scatter drug testing machine. And again, we're just a phone call away. So if these things happen either way, we just give the other organization a call and we just make it work. So SOS resources available to housing include mental health and addictions assessment and treatment on the spot. If the person's ready, we can start them on opiate agonist therapy the same day to lessen their withdrawal symptoms and provide them protection from overdose. We often provide wound care and treatment of infection. If we meet someone who doesn't have ID or a ride to the pharmacy or presents with other barriers to treatment, we can provide full courses of antibiotics, again, in the moment, same day. We had a lady sustain a dog bite that was living at the motel, and she was hesitant to go to the hospital, which many of our folks are for very good reasons. So housing was able to call on the paramedics and have us come and assess the wound, dress the wound, and provide medical advice and avoid that emerge visit. We also had a mental health counselor from the team come with us just to provide some supports as well. We also provide basic health necessities, food, support for travel, and safety planning. Housing provides SOS with the resources of the by names list and system knowledge, Landlord-Tenant Act knowledge, navigating shelters and communal living, as well as other types of housing. The housing team is made up of 6 staff plus a supervisor who provide diverse background and work experience. They have staff that have backgrounds working with crisis de-escalation response with police, a staff that had a previous career as a prison guard, staff with experience supporting women and families fleeing domestic violence, multiple staff with experience working with youth in mental health facilities or shelters. So a really well-rounded group of staff. For the SOS team, we have an NP that's an employee of the largest hospital system in the region and has many connections to call upon as needed for more challenging situations and cases. She's able to provide medical and addiction support and delegation to the paramedics on the team. One of our counselors has worked with youth for years, so she's a really good piece of the team to be able to support youth and gain that trust. Our social navigator helps people access social services and provide necessities of life. So all of our teams combined work really well within the harm reduction lens and provide support and care according to this mindset. I'm going to talk really fast because I know we're super over time. So encampment outreach, we already talked about this, but when SOS comes across an encampment, one of the first conversations we have is about housing. What brought you to Living Rough? What do you need from us today? If they want to be connected to housing, we will certainly arrange that. Again, somebody can meet us somewhere. We can facilitate transportation to have these conversations. But if they would rather, we can have the housing worker come out to the encampment with us. And this has already been discussed. They're very fluid, and what's happening in your day sometimes gets disrupted, so you can go and meet these needs that are much more important in the moment. Recently, there was a request from police for housing to attend an encampment in a rural area. There was little information provided on the needs, but SOS went out with housing, and we met with the folks that were living there. One of them ended up actually being pregnant. There was about 4 tents there, I believe. So we were able to provide them with supplies, and mental health counseling, got them onto the by names list. And again, it's those connections that we have, and police can be involved in their own specific ways. I guess, I hope that's helpful.
Yeah. I'm gonna whip through some things. We have a few pictures here. Like, did you know there's pigs at encampments sometimes? This is just a really cool structure someone built, so I like to throw it into the slide to give them some credit. We also, we're working on using this tool that we have developed around tracking encampments. So it's zoomed pretty far out just so you can't see the details of the encampments, but it is actually with the opioid overdose monitoring as well. And hopefully when it's up and running as it's in its full potential, we'll be able to use it to actually communicate through that portal with SOS and housing to kind of identify what the needs are of a particular spot and how we can respond to it. We don't do any enforcement, which is lovely, and I do meet with bylaw on a regular basis, and we honestly distance ourselves as much as possible from the enforcement side of things. Is this you?
So that's mine. I'm just going to skip through this. I think you guys get it by now. We support each other by advocating. We support each other by advocating. We all, like, this team is just so very solid. We all get it. We're all here for the right reasons, and we advocate for our, like, each other's services, but we advocate for our clients. This, I think, is really important, so I'm going to spend half a second on it. Shared training, I think, has been a really valuable piece that we've been able to pull off. So in May 2024, we did an all-day event where those 25 services that we talked about, plus more, came together in a space maybe twice this size. We sat down and we talked about stuff. We had people presenting on what the organization is capable of and what their limitations are, and this person is really not a fit for us, but maybe this is a better fit. So we did case studies, and we really had a chance to dive into relevant case studies as to what the different organizations can do and what they can't. We learned from Timmins, and again, it's just putting out those feelers that we want to do the best work we can, and how can we pull more people into our space so we can learn from each other. So another reason we're super happy to be here to learn from all of you. This summer we had a trip to Peterborough and learned from amazing organizations down there. And then in September 2024 here, we learned, again as a group, about more of the mental health aspects of things and how do we understand the system for Form 1, Form 2, all of those really tricky pieces. So that's been a really big piece in my mind of the success too.
Okay, we're almost done. So what have we learned? Number one, it's all about relationship building. And we talk about this with the folks we serve, that we need to have strong rapport and relationships with them. But it also goes for the folks we're working alongside. And with that, we also, both teams have shared values and common goals, and not in a formal way necessarily, but the hugest part of that is neither one of our programs are abstinence-based or recovery-based. We're also aimed to be client-focused, trauma-informed, and on our team, we do have a wealth of a variety of lived experience, and as a team, we really value that as well. And then the other piece I'll mention here is that both teams have such a strong communal commitment to building a positive work culture, and you can tell when we're together that both teams just have strong dynamics and strong commitments to work culture, recognizing that we do our best work when we're feeling our best at work as well. And then next steps, so we're wanting to come up with ways to track and compare data, to have our systems talk to each other to show how the collaboration is actually having positive outcomes for both health and housing. For folks that are familiar with HIFIS, we're actually talking about getting the SOS team on HIFIS, not without its barriers, but we're working on it. The nice thing about it is Teresa and I are both employed by the County of Grey, so getting Teresa as a paramedic on it will be quite straightforward. It's a matter of getting some of the other healthcare providers on it, such as Heather. And then lastly, we've been talking a lot about human trafficking and trying to build our team's capacities, especially with us owning a motel now, about identifying and responding to human trafficking. And there we go.
All right. Thank you so much to all of our presenters. Yeah, it's amazing to see all the collaboration that's happening in rural communities. And I think it's no surprise. I think that is really one, strength of rural communities is seeing, service providers come together to respond. And I'm sure there's probably a lot of questions. What time is it? I think we have, just about 15 minutes for questions. And so, if anybody would like to start off, otherwise I can definitely ask a couple, but does anybody want to start? Yes, go ahead.
I'm going to play that document, obviously. I'm in Dufferin, so clearly. The public, the health nurse, there you are. We have one in Dufferin, but it creates coordination with our OPP, so it's a health nurse and an OPP. Is yours the same funding or yours separate funding?
There are so many different funding streams. So we have MHART and MCERT. So CMHA funds a MHART program, which is a mental health counselor and a city police officer. MCERT is OPP and a hospital mental health worker. Yeah, so very different funding streams, but they both exist to try to fill the gaps in our enormous geography. And I'm not part of either of those.
Okay.
Yeah.
Because I'm thinking your role would fill a gap. So where does your funding come from?
Oh, so many funding streams. So we have 5 funding partners. So CMHA, United Way are our not-for-profit funding partners. Grey County and the Bright Shores Hospital fill in the rest. OH funding is now it's never stable, but we can kind of count on it for now until June. So there's that, but the county has stepped up and has committed energy into the work we're doing. No municipal funding. Yeah. No lower tier funding, sorry, that's the right language.
Lower tier, it's your upper tier.
Yeah.
So I'm assuming we wrote a proposal for that.
All the time. I mean, Heart Hub, the new $2 million available from federal, like all the time, right? So our not-for-profit partners are great at doing a lot of that work. I don't participate in that. I just give my opinion. Yeah, lots of opinions.
So I'm assuming would be a public document that we search.
Yeah. Oh, absolutely. And our county has been really great to share. So especially our director at Paramedic Services is happy to send the model, the terms of reference, like all of it is very available.
Excellent, thank you.
Cool.
For questions, do you mind repeating the question?
Good call.
Thanks.
Yes, go ahead.
I just have a question about assertive community treatment teams, because sometimes I'm in a rural county as well, so I'm somewhere kind of in the county. So I guess this is for both of you, because I'm not sure how it works in Quebec. But sometimes I find, like, because we're so far away from the hospital that the ACT team operates out of, the quality of care isn't quite there. Like, some people need daily or weekly visitations, that kind of thing. But I'm a harm reduction worker for a mental health agency, and like in my role, I find sometimes my hands are tied because people are attached to an ACT team, even though that care. So trying to coordinate with them is also hard because they're their own coordinated care. How kind of in a way too.
Well, it's actually timely and funny that you asked that, because this morning I had an email. Oh, sorry, repeat the question. How do I repeat all that? Basically, how do you work with ACT teams? Yeah. And so this morning, I actually had an email from an ACT worker that said, hey, when I walked into the motel and you guys were meeting that one day, what was that? And can we join? So that was our case management meeting that they, witnessed and wanted to join. So I feel what you're saying, like the ACT team locally does really great work, but often it is really based in physical health and in particular, and also mental health. But they have a occupational therapist that do a lot of work around mobility and things like that. But they're not, the way their program works is they're not available in the way that our teams are, Yeah. And they're,
I would even suggest that it's pretty collaborative. So, I mean, if there's an ACT nurse who can't reach somebody in a timely fashion, we will pick up the med, deliver, and administer a medication. I think it's quite collaborative. Again, I do work for the hospital corporation, so that's easier. The ACT team is part of the hospital, but we're quite collaborative, and it's not uncommon for folks to have 4 outreach workers. And it's not we've really gotten away from this my role, not your role. There's enough pieces of the puzzle for everyone to fit. There's not a lot of duplication as long as you communicate, right? Yeah.
Go ahead.
Question about when you do the eligibility for coordinated access. You may not be able to share this, but you did mention that you guys don't use the SPDAT. You guys are doing a tool that is in the works. But are you able to share kind of what that looks like? I am working on something for the community hub in Jones Place in London. So.
Yeah, totally. So we, the question was about, we don't use the SPDAT locally in Grey County. We use the in-house created tool and what that looks like. So it is, we basically spent some time researching what other communities are using, and we actually really like the Toronto Star assessment model. And one thing in particular is they have a directory of services that someone would indicate that they're either already connected to or want to be connected to. And we felt that that tool, was yes and no questions, but also gave opportunity for more narrative-based conversations and would indicate to us someone's needs as well. Now, that's only a small part of it, but that's just what we really liked from tools that we saw. Once we create our tool, I'm happy to share it, but a lot of it is we have some questions about demographics, so like what populations people are a part of and barriers that they might face as a result of that. And then we have more again, like really wanting to have questions that we can use to assess while also ensuring that we had opportunity for people to share their stories if they wanted to. So that's not really direct answer, but we're working on the tool currently, yeah. Yeah, so through we have questions around health, we have questions around past history of housing, like including like unit takeovers and things like that. And all of them ask the answers on like a sliding scale, and we're still figuring out how we're going to associate like a score to that, but we'll end up using that sliding scale to indicate. And then people also get additional points on that scale if they're from particular marginalized communities. So if someone's Indigenous, they automatically get another point. If they're a youth, they automatically get another point. So there's both that experiential based assessment as well as demographic assessments, recognizing that there's systemic barriers that everyone faces from that population. Yeah.
At the back there.
Just wondering if you could talk about the process of getting the approval to buy the motel.
Yeah, so the question was about the process to get their approval to purchase the motel. And I am very fortunate that I am a supervisor, so I don't often talk to county council. But my manager and his director do, and they spent a lot. Really, it was about that it just made more sense financially. It was a smarter decision money-wise to purchase our motel comparatively to us using the private market. So I think that was the major selling factor for council, was just it made sense money-wise. So it took a lot, though. It was a lot of, repeated reports at council to try to sell it. And yeah, I think that probably at the end of the day, the money part of it was a huge deciding factor. And then, when using the money opens the door to also talk about that it's lower barrier and all those kinds of things as well. But happy to connect also about that, because I don't have all the answers, but I can get the answers.
Yes, go ahead.
The RGI to BNL thing, so is it like 1 in every 10 units that becomes available, you just pull? And also, is that chronological on the BNL? Is it based on affordability? Mm-hmm. Is it equitable? Like, how is that?
So the question was around what the process is for the 1 in 10 rent geared to income units that the county does. We had started that it was every 10th unit, and then that just kind of got away of us. Like we had a fire in one of our buildings, so that pushed things back. So now how we're doing it is at the very least by the end of the year, if we offered 50 units that year, then 5 should be at dedicated to the by name list. So if we're behind, we can do 2 at the end of the year, kind of, yeah. But ideally it would be 1 in 10 and staggered. It is not through chronological wait list. It is through using our prioritization model on the by name list. I will say that has not been without its problems as well. So when we first had the 1 in 10, we attempted to put in the highest acuity, most folks that have been homeless the longest. And often the supports were very light touch and it really didn't work, and tenancies ended, and then that opportunity, like they'd be in arrears to the county and it'd be hard for them to get a unit again in the future. But what we're actually trying to do now is use it as an exit opportunity from transitional housing. So in Owenstown, we also have a 10 or 12 bed transitional housing unit that's ran by CMHA in partnership with the county. And so the 16 nonprofit units that I mentioned, we're trying to use the rent geared to income units as an exit point from that transitional housing. And what we do is, so say someone's on a year-long lease in this transitional housing unit, they do the year, had a great tenancy, then they'll go into the RGI unit and be on a 3-month transitional lease, and then following that go on to a traditional lease. There's always learning, and we're working along as we go, because one of the hugest barriers is that we don't really have units for families, because many families will go through like special priority applications will often be families, so they trump the by name list ones. So it's not without its problems. Some folks go straight into that from the by name list, but many people go from transitional housing to rent geared to income.
Thank you. And I do have a question for Christine and Antoine. I was wondering if you could maybe kind of expand and talk a little bit about like the engagement process and how you got community buy-in, from the service providers and practitioners for the clinical committee. If you could kind of maybe expand on that a little bit, I'd be curious.
No? Well, when the clinical committee started in 2015, I wasn't there, but we actually had a big political situation in the media. Actually, there was a TV reporter who came forward with alleged abuse from the police forces against Indigenous women. And when that came out in the media, there was already conversations with the different members of the committees that were working together, but not in a formal approach. And I think that's what allowed the different organizations to be like, we need to talk to each other. We need to find a way to actually sit down together and offer the right services for the users. So that's how it all started.
No, thank you. I appreciate that. Yeah, I come from Alberta, and some of the communities that we work with, they want to work towards that model, but getting the buy-in from, some other service providers can be challenging, and just due to capacity.
It had to be like in an emergency state that the organization said, oh, we need to do something about it. So that's why now we try to work really towards more prevention services. But yeah, and that's how the community police station came forward too, was created due to that crisis.
Yeah, thank you for sharing. And we probably have time for maybe one more question, if anybody else in the room wanted to ask any of the presenters. Yes, go ahead.
Remind question. I thought listening to Antoine's person, you guys had some great innovation that you did, like with your vanity stuff. And I was curious what the population of your community was.
It's 33,000 for Val d'Or. Yeah, so pretty small.
Is it a large area geographically?
It's pretty large. I'd say it's maybe like. That's a good question. We actually skipped that slide because we didn't. Well, most of our users are actually downtown, but there's no public transportation, so that's like something else for us. But on kilometers, like it's maybe on average, how many kilometers? No, we have no clue. I can Google that for you.
I'm just curious because the services are really innovative. It sounds more like a larger community, and I've always thought that Val d'Or was a smaller community. Am I correct?
Yeah.
Interesting.
But it's the entry of the north and the south, so we have a lot of visible homelessness. It's for that Val d'Or we have a lot of services, because we have a lot of visible homelessness and hiding too. So we try to be help of the time to develop some.
Awesome. Well, thank you everyone for your questions. And please, give it up for the presenters.